A very warm welcome to everyone. Today, our instruction course is basically designed for postgraduates, especially newly joined postgraduates, so that they can have an overview of the ophthalmology workups when a person walks into the OPD. It will cover the cornea and the cataract workups, the glaucoma workups, retina workups, the most dreaded squint and neuro-opthal workups. Uh, Now I'd like to invite my co-instructors on the dais. Dr. S.K. Chaudhary sir, head of NRCH, and he heads the retina services. My colleague Dr. Rishi, glaucoma services. Dr. Himani Thakur, squint and neuroopthal from RPC AIMS, and Dr. Nabil, cataract consultant at Uttarakhand. I'd like to invite Dr. Rishi to start with his presentation.
Good morning, everyone. Thank you, Dr. Saloni. Respected members on the dais, my talk on glaucoma and the current trends, how to navigate the pathways. I have no financial disclosure. Why to assess first for a patient who's coming to our OPD? So we have to first determine whether there is a presence of glaucoma, or to exclude any alternate diagnosis, understand mechanism of damage to guide management, and to identify the right form of treatment. So what to assess? So a patient comes to you, first go for the history, then examination, and then the investigations related. So in the history, most glaucomas, including the angle closure ones, are asymptomatic until advanced. Therefore, it's important that you ask the history of the patient. The medical and social factors will also affect the treatment. Plus, the patient with the older age and having a positive family history of glaucoma will also decide how his eyes are going to end up. Also ask about the past ophthalmic history like medications, steroids, any trauma, any history of eye surgery. So visual symptoms of glaucoma, usually in angle closure and pigment dispersion, you can see that the patient will come up to you with a visual blurring and discomfort. Rest, usually people do not complain of any symptoms. There can be glare, there can be colored halos. A very important symptom is that the patients will complain that they have very poor light and dark adaptation, that they move from dark to brighter areas or bright to dark areas. They have some difficulty. Plus, glaucoma patients have this thing, that is, they are not able to track high-speed objects. And especially if they are driving, then there can be crowding. So the factors affecting patients of suspected glaucoma, you have to ask about the respiratory, asthma, COPD that will limit the use of topical beta blockers. Then cardiovascular, any arrhythmia, systemic hypertension, migraine, blood loss. In endocrine, you should ask about the diabetes because it increases the prevalence of open angle, any existence of thyroid eye disease, any pituitary tumors. In CNS, if the patient is suffering from dementia, then it becomes really difficult to treat the patient. Then musculoskeletal, patient will have arthritis, so he'll have difficulty in putting the eye drops because his fingers will be very difficult to push that drop. Patients with urinogenital stones, that will limit our use of carbonic anhydrase inhibitors. Then any history of ocular trauma will lead to angle recession or lens dislocation. So the management will change. And for a steroid of any route of administration is always associated with ocular hypertension or open angle glaucoma. In such case, the treatment differs. We have to minimize the use of steroid. Then the prolonged use of glaucoma drops may increase the trap failure. Plus, a patient already on anticholinergics or TC antidepressants, that can lead to angle closure. And a person already on systemic beta blockers and calcium channel blockers for hypertension will interact with his topical beta blockers. So how to examine the patient? You should have a good slit lamp with indirect lens, 90D preferably, or a direct ophthalmoscope. Then you should have an automated perimeter, a gonioscope, and a tonometer. Now, what are the factors which affect the IOP measurement? There is a circadian rhythm related to our IOP. Usually it peaks at around 4 to 6 a.m. and then troughs at around night. So that diurnal variation is around 3 to 6 millimeter of mercury. But in patients of glaucoma, the variation is more, and it can be more than 8 millimeter of mercury also. Then the thinner corneas, they artificially lower the intraocular pressure. Blood pressure, especially the systolic pressure, if high, can lead to higher IOP. And with each decade change after 40, there is a rise of 1 millimeter of mercury in the IOP. Plus, there are yoga head down positions, the postures which involve downing your head can further increase the IOP by 2 to 6 millimeter of mercury. And use of alcohol may decrease it. So the measurement errors with the GAT are that they can be artificially low if you do not put the proper fluorescent. It can be high if the patient is not comfortable, he's squeezing his eyelids, or you are putting a digital pressure on the globe if the patient is obese, breath holding. Other difficulties are like patient are already having a scar, a graft, corneal edema, astigmatism, nystagmus, small aperture, or any tremor. So in the entry segment, you will look for any episcleral blood vessels, any follicles. Entry chamber, look for pigments on the endothelium, KPs. And for the iris, look for any mid-dilated pupil poorly reacting or isolated zones of patchy atrophy, rubiosis, synechia, pseudoexfoliation, transillumination effect. These are the things you have to look. And on the lens, you can look for pseudoexfoliation material, lens thickness, the phacodonesis, and glaucom flecken. Now coming to the gonioscopy, you have to detect this angle closure, whether it is occludable, or there are secondary glaucomas where the angles are open but they are blocked. Look for angle width. Now suitable illumination is required, which is low, good anesthesia, smallest slit possible, and with the highest magnification. Now set your slit lamp on the upper cornea of the gonio mirror, where you can see the inferior angle first. Don't put the light on the pupil, as it will artificially constrict the pupil. Then you can go and examine the nasal and the temporal side. Now if the scleral spur is visible, then record your findings. If it is not visible, then you can see for any indentation, and if the angle open, then it is like primary angle closure. And still, if you see that there is associated IOP rise, then it is angle closure suspect. Now in angle closure, you will see pass, then there will be pigmented patches over the trabecular meshwork, which is sign of iridotrabecular contact. Then there will be, in the abnormal open angles, there will be TM pigments. Then there will be new vessels, abnormal iris processes. Ciliary body, look for any angle recession, any cyclodialysis cleft. And in some cases, you can see the blood in the Schlemm's canal. So how to examine the optic nerve head and the retinal nerve fiber layer? You have to see the disc size, the neuroretinal rim. And here, the importance is the size of the disc altogether. If a large disc is large, so it will have a larger cup disc ratio, but the rim will be having a good circumference. Therefore, it may not have any nerve fiber layer damage. So there is a chart where you can see that a small disc will have a mean cup disc ratio of 0.26. But in a disc of more than 2 millimeters, you can see that a mean cup disc ratio is 0.55. So both these are normal. Now, in a patient, when he comes to you, always draw the optic disc, the rim, the key vessels, any notches if you see, any shelving or any particular rim thinning of the rim in the clock hours, whether the Isent rule is followed or not, any visible defect if you have dilated the patient. Also note the vertical CD ratio. if it is possible to take a optic nerve photograph, then do take it and hand it over to the patient, so that when next time he comes to you, he has a recording and you can compare. Also note for any hemorrhage, bearing of circumlinear blood vessels, any bayoneting, and large discs have large CDR, even though NRR is normal, which we have talked about. So here you can see that in a moderate glaucomatous optic neuropathy, localized loss of both inferior and superior neuroretinal rim is there. And a classic inferior notch can be seen, where in the small arrows you can see. And NFL defect in both the superior and inferior arcuate will cause a visual field defect. In the advanced optic neuropathy, neuroretinal rim thinning is very large, and the cup extends to the disc rim. It's almost 0.9. Then there you can see circumlinear blood vessels bearing, bayoneting of the blood vessels. The peripapillary atrophy is also there. And in visual field examination, it defines the state of the optic nerve function and the visual impairment associated with it. Automated perimetry helps when glaucoma is suspected. So if a patient comes to you, you can order a automated perimetry, and the characteristic of that glaucomatous damage will be shown by the asymmetrical across horizontal midline. And it will be located in the mid periphery, around 5 to 25 degree of fixation. Then there will be clustered defects in the neighboring test points. And this defect correlates with the optic disc picture and the examination you have drawn. So the goal of treatment is the risk factor reduction, the IOP, and look for any angle control if angle is shallow, what all you can do, and treatment of the predisposing disease like diabetes, uveitis, and steroids. So the objective is to maintain a functional vision throughout the patient's lifetime with good quality of life. A slow disease in an elderly patient results in little progression, but a patient coming in a younger age and having a faster disease will lead to blindness. So our goals will be to deepen the angle, to give an iridotomy to reduce the pupillary block, and we can use lasers to do iridoplasty, and we can also do lens extraction early to reduce any pupillary block. Usually if lens swells more than 4.3, 4.4 millimeter, it's better to extract it in early stages. And in cases of malignant glaucoma, we have to go for vitreous surgery. So the target IOP, what is target IOP? In a treatment naive patient, record the IOP of the patient when he is coming to your OPD. And it is based on the pressure reduction required to slow down the disease progression. So we have 4 groups of glaucoma, where the first group is having a high risk of visual loss. That is definite optic neuropathy can be seen with visual fields loss. So we have to reduce the IOP by around 30%. That is like lower teens. And in group 2, where the glaucoma is having a moderate risk of visual loss, that is mild GON can be seen, early visual field loss, or in ocular hypertension with more than 30 millimeter of mercury pressure, then the reduction required is around 20%, that is mid-teens. And in a glaucoma suspect, you can see that there is suspicion around the disc, the fellow is having established optic neuropathy, the OST with suspicious disc, then you have to reduce further by 20%. And in group 4, where there is low risk or they are associated with having a family history or PAC or PDS, fluid exfoliation, hemorrhage, then in such cases you have to, you may not start the treatment at once, and you have a close monitoring and see the progression. So we have laser treatments available, and in that we have laser trabeculoplasty, which actually burns the trabecular TM and opens the channels. While in cases of end stage where there is usually the patient is PL denied, then we can reduce the inflow by doing a cyclophotocoagulation. In PACG, patient coming to you with pupillary block, do a laser PI. And in end stage, again, you can do cyclophotocoagulation. So in laser spots, you have to see that if you are using the power, then it should be around 300 to 1200 milliwatts. The spot size should be around 50 micron for argon and 75 for diode lasers. duration should be 0.1 second. You can give 30 to 50 spots evenly spaced over the 180 degrees. So I will recommend that you give around say, half of the 360 degree at once. Don't give full 360 degree once on one sitting. It can cause temporary blurring, IOP spike, and some pass can be there, or it can also lead to chronic increase in IOP. It is effective, relatively non-invasive, preferable to surgical iridectomy. Cyclophotocoagulation reduces the production of aqueous by destroying the ciliary epithelium for cases where we have failed multiple filtering surgeries and we have to alleviate the pain of the neovascular glaucoma, the patient is having painful blind eye, and surgery is not possible. So we have drugs which are prostaglandin analogs. We are all accustomed with that: bimatoprost, latanoprost, travoprost, beta blockers, carbonic anhydrase inhibitors. There are new generation of drugs, ROCK inhibitors. So I'll not go into the details. Then we have surgeries which are the traditional penetrating filtering surgery, trabeculectomy, and the non-penetrating surgeries. Then we have glaucoma drainage devices, the Emmett glaucoma wall bare welt. And the newer thing is to have a lens extraction, early lens extraction in cases of PSEG, and goniotomy and trabeculectomy for childhood glaucomas. And there is option of MIGS, which is micro-invasive glaucoma surgery, which was recently developed by Dr. Ahmed in 2008. Thank you.
Thank you, Dr. Rishi, for a comprehensive glaucoma workup. Now I'll start my presentation. Dr. Saloni Gupta. Basically, we are here to present clinical techniques for basic new postgraduates for corneal examination and for cracking the refractive code. We all know that the most important modality for examining cornea is proper slit lamp examination. After making a basic suspicion, we can go on to corneal topography, specular microscopy, anterior segment OCT, confocal microscopy, etc. Slit lamp, we can use various illumination techniques, and mastering all these illumination techniques is very important for a detailed corneal examination. Like diffuse is used for any gross abnormality and contact lens fitting. Optical section is very important for delineating the various corneal layers. The dystrophy deposition is at width layer, corneal foreign body, corneal curvature, thinning. Indirect is important for corneal microcyst. Retroillumination is especially useful for endothelial deposits and epithelium vacuoles. Specular is best for any endothelial dystrophy, and sclerotic scatter helps to localize a very faint, subtle corneal irregularities. Specular microscopy is basically used to diagnose pathological changes in endothelial disease. It is used in eye banking for assessment of donor cornea and for pre-op endothelial health survey. This is a normal specular microscope. We have to see basically the cell density, which should be more than the age appropriate number, more than 2500 for a young person. The 6A hexagonality, which should be more than 50%, and the coefficient of variation, which should be less than 33%. This is a case of endothelial dystrophy with the decreased coefficient of variation and increased 6A and cell density. It is useful in conditions like Fuchs, PPMD, iatrogenic corneal endotheliopathy, and post-penetrating keratoplasties. Anterior segment OCT is also an important tool for defining the various layers of the cornea. It's especially helpful in keratoconus, even in hydrops case, to see the edema. For corneal dystrophies, to see the layer of deposition. It helps in monitoring the progression of infectious keratitis and the management effect. It is very useful in DMD to localize it, to classify it, and then to treat it. It is also useful for anterior segment surgeries, like planning of preoperatively DALC, DSEC, DMEC, and also intraoperatively in the form of IOCTs. Like this is a picture of keratoconus with acute hydrops, and this is showing deposition in anterior stroma in early granular dystrophies. Now, another important tool for postgraduates is corneal topography. It can be based on Placido disc-based, slit scanning technique, and Scheimpflug, the most commonly used is the pentagram. The printout comes as a map of 4 known as the quad maps. It has the patient details, it has the keratometric values, pachymetry values. The first map is a very important map, the axial or the curvature map. It represents the anterior curvature of the cornea and represented in the form of dioptric values. The average dioptric value is 43 to 46 diopters. Anything more than 47, 47.2 to be exact, is considered to be suspicious for ectasia. The warmer colors represent the higher dioptric values or the steepening and are at risk. Next are the elevation maps, the anterior and the posterior elevation of the float maps. This is when we compare the anterior and the posterior curvatures with a reference or a best fit sphere, and anything more than 15 micron in an anterior and more than 20 micron in a posterior is suspicious for an ectasia. Then last is very important is the thickness map. It tells the thickness of individual points of the cornea, and the thinnest point should be at least 470 micron to prevent any form of ectasia in the future. This is a bad map. This is especially important for any keratoconus borderline cases because it compares the reference cornea with the enhanced best fit sphere, and here also the warmer colors represent that there is a risk of keratoconus or any other form of ectasias. In keratoconus, we have to basically look for 3 points: the increase in the area of corneal power more than 47.2, inferior superior asymmetry more than 1.4, and skewing of the axis more than 22 degree. Like we can see a asymmetric bow tie here, suggestive of keratoconus. It's mostly seen in axial curvature map, and in this we can see a crab claw foot in a PMD case. Now after all this, this is very important for planning any refractive surgery. We'll learn a basic about how to pre-operatively decide which patient is fit for refractive surgery and which is not. Refractive surgery can be cornea-based procedures or the lens-based procedure. Here we will mainly be discussing on the corneal-based procedures. The FDA-approved range for various refractive procedures are the following: LASIK minus 10 diopters to plus 4 diopters. SMILE is minus 10 and up to 3 diopters of cylinder can be corrected. However, the range can be increased if we are using a lens-based procedure. After a proper consent and a proper history, we have to calculate the BCVA with cycloplegic refraction. The PMT and the POG shouldn't differentiate more than 0.5. There should be a stable refraction for 1 year. We have to measure the pupil size, intraocular pressure, anterior segment, posterior segment for any lattice holes, proper TFL assessment. And now to find out if the patient is fit for cornea-based refractive surgery, most important are the investigations. 4 parameters are very important. First, we have to see that Kmax should be less than 47 diopters. CCT or the thinnest point thickness should be at least more than 480 microns. We have to calculate the RSBT or the residual stromal bed thickness that we calculate by subtracting the flap thickness and the depth ablation from the central corneal thickness. The flap thickness usually varies from surgeon to surgeon and can be 90 to 120 micron. And the RSBT should be at least 250 or preferably 300 microns for performing any corneal-based procedure. Percentage of tissue ablation is altered is also calculated, which should be less than 40% for any risk-free corneal-based refractive procedure. It is calculated by flap thickness plus ablation depth divided by central corneal thickness. After calculating all these scores, we can calculate the Rendelman ectasia score. The higher the score, the more the chance of ectasia and more the patient is unfit for carrying out any cornea-based refractive procedure. As we have already discussed, beside all the calculations, corneal topography should be within the normal range for any corneal-based procedures. If it any suspect, we should wait, give a time of 3 to 6 months and then follow up the patient. Bad map is very important. All the 4 quad maps are important. Besides the corneal topography, corneal biomechanics is also very important. We'll come to that. If there is any at-risk corneas, we should always defer the surgery or plan the patient for a lens-based procedure. Corneal biomechanics is very important in the form of CBI and TBI, Corvis Biomechanical Index or TBI. These should lie in the green zone so that the corneal biomechanics is maintained even after post-corneal based refractive surgery. If all these factors come into within the normal limits, like age of the patient is more than 18 years, there's a stable refraction, no ocular systemic contraindications, all the parameters like CCT is more than 480 micron, RSBT more than 250 to 300 microns, PTA less than 40%, no indication of any form of ACRs, posterior elevation less than 15, bad map is normal, then we can proceed to the surface ablation techniques, LASIK or small, any corneal based procedures. LASIK is suitable for most cases and cylinder is suitable for moderate powers. However, if they are not suitable, then we have to proceed for the lens based procedures or the phakic IOLs. Thank you. Now I'd like to invite Dr. Himani Thakur to give us an overview of the most dreaded topic, squint for residents.
A very good morning, everyone. I would like to start by thanking Dr. Saloni for the opportunity. I'll be discussing squint secrets, precision, and eye alignment. So the most important aspect, like any other specialty, is history. You have to ask whether the strabismus was acute or gradual. What was the frequency of deviation? Is it constant or intermittent? Is it unilateral or alternating? Is there any diurnal variation or progression or any cyclic nature of the disease? Does the patient have diplopia? And how is the deviation changing with spectacles? Any history of developmental delay, any systemic, any neurological history, any family history, and birth history also is important when we are concerned with strabismus. So the most important aspect of the examination is visual acuity assessment, diffraction, and detection of amblyopia. Next is the motor examination, sensory, and the supplementary tests. I'll be discussing the motor, sensory, and supplementary examination today. So the first thing is to establish whether the strabismus is true or pseudo. So we have to do a careful adnexal and angle kappa assessment. Pseudo-exotropia presents in cases of hypertelorism and positive angle kappa, and cases with telecanthus and epicanthus and negative angle kappa most commonly presents as pseudo-esotropia. But we have to know that this is apparent squint and not true squint. A motor alignment or motor adaptation to avoid diplopia is head posture. Head posture depends upon the axis of the deviation. It can be chin up and chin down, face turns, and tilts. Whenever we do a squint workup, the most important thing is how we are assessing the extraocular movement. So this is the primary gaze, and this is the dextroversion, levoversion, circumversion, dorsumversion, and all these 9 gazes are important, and we have to look for any limitation of movement in any particular gaze, and then we can grade it according to a point system. Next, we are concerned with the cover and uncover test. The prerequisites are that the patient should be able to fixate and should have a central fixation. Also, any gross motility defect would limit our findings. So, in a cover test, what we do is we cover the fixing eye and look for the movement of the squinting eye. In uncover test, we can put occluder on any eye. So this is the undercover test while we observe what is happening undercover, and uncover test is how the eye comes back or how the eye reacts when the cover is removed. Deviation can be measured objectively or subjectively. Objective tests, the most commonly that we use are prism bar cover test. So we have to remember that prisms can be of two types, glass or plastic. The apex is put towards the deviation. Like this was the case of exotropia. So we have put a base in prism. And end point is when there is no movement of the eyes on alternate cover test. So in the video we saw that the patient's eye was coming out to in, and we neutralized it till there was no movement. It is important to know how the deviation changes with distance and with near. For example, in cases of IDS, the patient might have no deviation at near but will manifest at distance. Also, how the deviation is changing with the spectacles. For example, in this case, this is an accommodative esotropia where you see that the patient is esotropic without glasses, but the correction is absolutely neutralized when he wears spectacles. Another thing that we have to measure is the deviation in up gaze 25 degrees up and down gaze 35 degrees down. This tells us about any patterns that there might be, like a V pattern or an A pattern or an X pattern or a Y pattern. These patterns are important when we have to decide for the surgery. Another method to measure is a Hirschberg test, which is based on the estimation of deviation by observing the first Purkinje image. So the first thing is 0 degree when the corneal reflexes are absolutely aligned. And if they are falling on the pupillary border, that is 15 degree. Between pupillary border and limbus is 30. And at the limbus is 45 degree. We can also grade or quantify the measurement with the Krimsky test. In a Krimsky test, it is a corneal reflection test, but a prism is also being used. So prism is placed over the squinting eye, and we need to neutralize it using a prism. A modified Krimsky way is a modified version of the test, where we, in spite of the deviating eye, we place the prism over the fixing eye, and we see how the eye is moving as we are neutralizing it with the prism. So we see now the eye is centered, which was initially in esotropia. Now the sensory examination again consists of visual acuity, Bagolini, word 4 dot, synoptophore, diplopia charting, and tests for stereopsis. So Bagolini's striated glasses are a pair of plano glasses with striations that are 45 and 135 degree. So what we are going to do is we are going to convert a point source into a line source of light. This is the least dissociative and the most physiological test. So this is how the patient might interpret the test. So we ask the patient or tell him to draw whatever he's seeing. This is a normal symmetric cross response. It is seen in orthotropic patients or heterophoric abnormal retinal correspondence. Asymmetric cross response will be seen like this, where the cross is asymmetric. In cases of central suppression scotoma, the center part would be missing, and in cases of a suppression response, the suppressed eye image would not be seen. Word 4 dot is based on red-green color dissociation. We wear a red-green glass, red over right eye, and these 4 dots arranged in rhomboid pattern have to be seen. So these are also interpreted in a similar manner, where all the dots would be seen in cases of orthotropic, in cases of orthotropia, and in cases of suppression, the counterpart eye would be suppressed. Like in left suppression, the patient will only be seeing the right colors, that is red, and in right suppression, the green colors. In exo and ESO deviation, patient will perceive diplopia. So in ESO, there will be cross diplopia. In exo, there will be cross diplopia, and ESO, there will be uncrossed diplopia. Synoptophore is an instrument which is based on the haploscopic principle, where there is mechanical dissociation of two eyes by means of two optical tubes with angled mirrors. So it has multiple uses and is a separate topic altogether. It has diagnostic uses in the measurement of deviation, fusion ranges, binocularity, retinal correspondence, and therapeutic uses in cases of fusional vergence exercises, treatment of anomalous retinal correspondence, and amblyopia therapy. So these are some of the slides that are very commonly used in synoptophore. So in cases of simultaneous perception, one eye sees the cage, the other eye sees the lion, and if the patient can perceive simultaneously, he sees a lion in the cage. In fusion slides, they are slightly disparate slides. When seen binocularly, the patient would be able to see the complete image. And stereopsis slide, with both the eyes binocularly, patient will have a 3D perception. Next is the diplopia charting. So how we do it, we usually take a streak and the patient, the test is done in a dark room. We use red-green glasses, again red in front of right eye. It is done at 1 meter distance. So there are two ways to do it. Either you project light on the screen or directly onto the patient. And then the patient is asked to draw what he sees. So if this is the right and this is the left, and I am drawing as a patient, so in cases of right LR palsy, we see that the diplopia would be maximum in the right case. The tests for stereopsis are for near TNO test, Titmus stereofly test, Randot test, Lang's test, Lang's pencil test, and for distance Frisby-Davison, distance Randot test. So Lang's 2-pencil test is a very common bedside test. It is a gross method. What you do is you tell the patient to point his pen to your pen. It can be done in a vertical or a horizontal fashion. The TNO test is based on anaglyph principle, where we use red-green glasses, and the plates are such that using complementary colors, in binocular patient, they'll be able to perceive a 3D image. So they have gross stereopsis plates, suppression plates, and even the quantitative plates from 480 to 15 seconds of arc. Titmus stereo fly test this is how it looks like. So there is a gross stereopsis plate where you can see the wings above from the plate. And then there are animal images where we ask the patient which animal stands out. It is based on vectographic principle, and Polaroid glasses are used. Randot test this is how it looks like, and random dots are arranged when viewed through Polaroid glasses. The patient will be able to perceive a 3D image. The benefit is that it has no monocular cues. Distance Randot test plate is the same, but the difference is that it is done at 3 meters. This is how a Lang stereo test looks like, and it is important to know because this does not use any glasses. The cylindrical lamination is there on the test plate, so you do not use a special glass. It is very common and easy to use in children. So around 60 to 550 seconds of arc can be seen in Lang's 1 and 200 to 600 in Lang's test 2. A Frisbee-Davis test is a test of real-time depth perception. So 4 floating objects are placed in an illuminated box. Now there is a modified new Frisbee-Davis test where they have removed the cabinet type of structure and the targets are unchanged, and we move this frame is moved. And based on the chart that they provide, they measure the stereopsis. Supplementary tests are a lot, but I'll be touching only a few. So AC by ratio, torsion, Parkes 3-step test, Hess charting, force reduction test, and AFGT. AC by A ratio is important in squint measurement, especially in cases of esotropia and IDS. So there are 2 most common methods, heterophoria method and lens gradient method. In heterophoria method, the deviation is actually measured at distance and then measured at near. In lens gradient method, we do not change the patient, but we use lenses to change the accommodative status. So minus glasses will increase accommodation and plus glasses will decrease accommodation. Torsion can be measured using indirect ophthalmoscope, fundus photograph, blind spot charting, or by double Maddox rod, Bagolini, and synoptophore. So normally, fovea is located at between midpoint of disc and the lower border. So if that is above that, that is encyclotorsion, and if it is below that, that is excyclotorsion. So using AI and a protractor, you can actually measure how much is the amount of torsion. Again, double Maddox rod test is used to measure cyclodeviation. So these rods are aligned with the 90-degree mark, and this is how the patient perceives it. So what we have to do is we have to ask the patient to rotate the rods until both the lines are parallel. So this is a Hess screen. It is based on haploscopic principle. The central field is 13 degree, outer 30, and each square marks 5 degree. So this is a metallic screen. Patient wears red-green goggles, green over the eye to be tested. So the patient has a red light which is illuminated by the examiner, and patient is asked to place his green light over the red. Thank you so much.
Thank you, Dr. Imani, for such a comprehensive cover. Now I'd like to invite Dr. Nabil for cataract workup for postgraduates.
Good morning to one and all. So my talk is aiming at cataract evaluation and a bit about biometry, and mainly for residents. I have no financial disclosures to be made. So for chief complaint, the actual evaluation starts with history taking. And we must learn the art of listening, because sometimes the complaints might not be related to cataract per se, but can be relevant for patients. Anything like itching, foreign body sensation, we have to listen to that and try to address that as well. Now, in the history of presenting illness, we must inquire about the onset, if it is definitely diminution of vision because of cataract. We need to know whether it is painless or with pain, and we need to know the nature, which is whether it is progressive or stagnant. We need to know about the treatment history. Hypertension, very important. We need to know about diabetes status, thyroid-related ailments. We need to know about CADs because patients may be on blood thinners. And not very important for topical surgeries, but for block, we tend to stop Ecosprin for 3 days and clopidogrel for 5 days. We need to know about BPH because patients on tamsulosin and Urimax may have intraoperative floppy iris syndrome, and your planning changes. Your incisions are more corneal, long tunnel length. You might have to use a pupil expansion device. You want to know about rheumatoid arthritis because that can be associated with AC reaction and cells. You need to know about steroid intake, oral, topical, local, everything. And you need to know whether the patient is taking treatment for glaucoma because ideally we should stop prostaglandin analogs before surgery for the washout period, which may be 2 to 4 weeks. Past history is very important, and leading questions might help here. Please ask about previous ocular surgeries because if you don't ask, patient might not mention about refractive surgeries. And everything changes because the biometry changes completely. And you need to ask about trauma. When I see a white cataract in a younger patient, I do ask about trauma, diabetes, and recent intravitreal injections. Very important. You need to know about personal history. Addiction, important because smokers don't usually get the effect of the block very early. Coming to general examination, you would want to see the pulse rate. Shouldn't be very tachycardic. Blood pressure, if it is high, you need to treat that before surgery. And saturation. Now coming to ocular examination, you need to document the visual acuity. Both uncorrected, best corrected, and vision with pinhole, very important. You need to document IOP, preferably with a non-contact method. You need to document the head posture. Do not directly jump to cataract examination. Do see the lids and adnexa. At least do a Roplast test if not syringing. Do document if there's any deviation. Could be sensory exotropia because of hypermature cataract, or could be a pre-existing deviation. Do document extraocular movements. Coming to slit lamp examination, please examine the conjunctiva quite well. If possible, avert the lid. Do examine the palpebral conjunctiva as well. Many a times the patient might say they have a foreign body sensation, and you might see a small foreign body hiding in the sulcus subtarsalis, so that becomes important. Do examine the sclera because it's a tendency we sort of jump to cornea examination when we see a cataract patient. Do examine the sclera as well. Cornea, very important. And corneal examination should be methodical. You should see the size of the cornea, the sheen, the transparency, if possible sensations, and do a specular reflection to assess the health of the endothelium. Do examine the anterior chamber for content, cells, depth, iris for any neovascularization, any pigments, any cysts for that matter, and pupil. Please do not directly examine the patient for cataract surgery when they are dilated. Many times what happens, they are dilated before they are brought to you. Do see them undilated. Document the pupil size, pupillary reaction. If there's any anisocoria, do document that. And pupil size becomes very important. If a patient has senile miosis, might not be a favorable patient for multifocal implants and EDOF sometimes. So that becomes very important. Do document as to how much is the dilatation. Because the surgical planning changes. If patient is dilating only 4 mm with all your pharmacological agents, it becomes important. You might need a pupil expansion device. You might need iris soaks. You might need rings for that matter. And do document as to how much the patient is dilating. And then comes the cataract grading. So the latest grading that is being followed is LOCS 3. So color coding is there. So what we usually do is see on an oblique illumination, we see the color of the nucleus. So the trick is GYABB, grayish, then yellowish, then amber, brown, and black. And for cortical and posterior subcapsular, do a retro illumination and grade according to the guidelines. Do document if you see a posterior polar cataract. Then again, the planning changes, the surgical method changes. Some things are to be avoided. Some things are contraindicated, and your planning changes. You need to have a 3-piece IOL as a backup. You need to have anterior vitrectomy setup and all. Particularly important is the type 3, where you see a diagnostic sign. The white dense spots are grayish spots on the posterior capsules are quite risky because they are often associated with extreme thinning and pre-existing defects sometimes. Do examine the anterior vitreous. There could be vitreous opacities, floaters, asteroid hyalosis. Coming to fundus, we most commonly do it with a 90D. Some people do it with 78D. It's completely all right. And if possible, do an indirect ophthalmoscopy for periphery, because many a times we don't see the periphery, but some lesions can be present, particularly if the patient is myope. Coming to investigations, do a macular function test. So there can be many, like Amsler grid, photo stress test, 2-point discrimination test. If possible, do an OCT macula, but that can only be done when the media is relatively clear. In opaque media, completely opaque media, white, mature, hypermature cataract, and very dense cataract where the fundus is not visible, you can go for ultrasound B scan. Document the counts with specular microscopy, but then again, it comes with a cost. Not every practitioner would have this machine. So therefore, it's very important to have a specular reflection view on the slit lamp. Do a xylocaine sensitivity test if you are planning the patient under block. For investigations, blood sugar, fasting, and postprandial is important. And I personally go for viral markers as well, but then some people go for it and some do not. And biometry. Biometry is something, many a times what happens is the biometry is being done by residents, although the number of cases are more done by the consultants. And we don't pay good amount of respect and the time to biometry which is required. So we need to have some basic understanding of biometry. So let's do that scenario-wise. Case 1. So you can see the K values are in the normal range. The AC depth is in the normal range. The lens thickness is in the normal range. The axial length is in the normal range. Nothing unusual. And for calculation purposes, I have taken A to be 118, A constant to be 118.8. SRK formula gives, for emetropia, it will give around 20.44. SRKT will give 20.62. And Barrett Universal 2, which is a 4th generation formula, quite well accepted now, will give around plus 20.37. So for this particular patient, aiming at emetropia, I would probably put a plus 20.5 IOL, with the steep axis planned at 101 degree, because that also needs to be accounted. There's a difference of 0.25 diopters for the K values. So what's important here is for normal values of the indices in biometer, all the formulae will give nearly the same results. But see a second case where the K is very steep, and here SRKT will fail. There's a difference of around 1 diopter, and 1 diopter is good enough to surprise you and the patient. So I would prefer a Barrett Universal here, because SRKT has a limitation. It underperforms in steep case and flat case. Case 3, the K values are normal, but the axial length is a little less. It's a short eye with a normal AC depth. So there's posterior shortening. And here also SRKT will underperform. You can see a difference of nearly 2 diopters. So we need to know this, how to select the formulae. For very short eyes, that is axial length less than 20, we would prefer Holiday 2 and Hoffer Q. For short eyes, axial length 20 to 22, we'll prefer Hoffer Q. For normal axial length, SRKT, Hoffer Q, Holiday 1 gives good enough results. For long eyes, nearly 24 to 26, we prefer Holiday 2. And for very long eyes, more than 26, we prefer SRKT. For steep case and flat case, we avoid SRKT. And effective lens positioning or effective lens position is best predicted by 4th generation formula, which is Barrett Universal, Haggis L, Holiday 2. So coming to special scenarios, if you have a refractive surprise and you are planning a piggyback IOL, so for myopic surprise, whatever refraction is coming, you multiply it with 1 times the refraction, and you get the power to be implanted for piggyback IOL. And piggyback IOL is a sulcus IOL, 3-piece IOL placed in sulcus in front of the IOL which has already been placed. If the refractive surprise is hyperopic, you multiply with 1.5. So 1.5 times the refraction, you get the value. Very important for sulcus IOL. If you have a PCR, you do an anterior vitrectomy, you have cleared all the vitreous, now you want to place a 3-piece IOL in the sulcus. So whatever power you have calculated for the bag, in the bag placement, so what you need to do is, there's a rule of 9. For 0 to 9 diopter, you do not reduce any power. For 9 to 18, you reduce by half. For 18 to 27, you reduce by 1, and for more than 27, you reduce by 1.5, provided you have accounted for the A constant, because A constant difference will also have to be accounted. If the A constant for this particular IL is half diopter less than the one originally planned, then that also has to be accounted. For scleral fixated IOL, usually in the bag IOL power fits well because SFIL anyway sits quite posterior. For vitrectomized eye, usually we prefer to increase the power by 0.5 because when the vitreous is not there, the aqueous is there, the PC sits slightly posterior. For triple procedure, so you're aiming an open sky procedure, PK, cataract, and IOL procedure. So what you're doing is generally taking the K values from the other eye and doing an ultrasound biometry for this eye, for axial length, and you calculate it. Most important in today's world is post-refractive surgery. So what happens is, in RK eyes, you do see during the examination, but a LASIK eye can easily be missed on examination if you're not careful and the patient is not telling you. I've seen sir operating a lot of RK eyes, and we used to do the calculations together. So it's and the surgical planning also changes in RK eyes. You don't have to intersect the incisions, the wound is a little scleral and all. So what I believe is today we are seeing more of RK eyes, but 10 years down the line, when probably I become a senior surgeon, then I would be facing more of post-LASIK eyes. And it's important to consider that normal formulae, normal considerations will not apply to this. For myopic LASIK, you will end up with a hyperopic surprise. So you need to have topography, tomography considerations. And the formulae will be Barrett, True-K, Hagies-L, and AI-based formula like Hill, HRF, and Lada's super formula. Thanks.
Thank you, Dr. Nabil, for such a nice coverage. Now I'd like to invite Dr. S.K. Chaudhary, sir, the last talk of the course for retinal examination for postgraduates.
Good morning and welcome to all of you. Although this session was planned for PG students, but I'm not able to see any, but still. So I'll be sharing my experience regarding retinal examinations here. So the natural advantage about retina is this, that retina is fully visible. It's not hidden like optic nerve, choroid or ciliary body. And all disorders of retina are also visible, and we have multiple diagnostic tools, and we need not to guess anything in retina. Everything you can see, you can diagnose. And you must know the normal appearance of the retina so that you can make the difference that there is something abnormal in the retina, and then you can think of making the diagnosis. So you must know what are the common retinal disorders so that you can plan your investigations and you can plan your things to reach the conclusion and diagnosis. So commonly we know that diabetic retinopathy is there, in which the changes are mostly located at the posterior pole. Same is the hypertensive retinopathy, changes are at the posterior pole. Age-related macular degeneration, CNVMs, disease of posterior pole. Retinal vein occlusion, posterior pole. Retinal detachment, it involves initially the periphery, then comes to center. Lattice and breaks, these are the problems of periphery. Retinal degenerations involves whole of the retina. Same dystrophies involve whole of the retina. Vasculitis, usually peripheral vessels. CSCR, central retina, posterior pole. And retinitis, viral retinitis involve most of the retina, and tumors depending upon type of tumor may be at posterior pole or at periphery. So what all equipments we have to examine the retina, and we must know the ideal use of them. So we can see retina even on the torchlight also, like if retina is fully detached, and certain tumors like this retinoblastomas sometimes visible on the torch. Then slit lamp, we can see many things in the retina even on the slit lamp also, particularly in the high myopathic patients. And then direct ophthalmoscope is a very handy and commonly useful tool for residents, particularly in initial days. Then indirect ophthalmoscope, then slit lamp biomicroscopy, USG scan, FFA. This is also the list of commonly available equipments we have: OCT, OCTA, ICG, FAF, ERG. So we have all these tools to examine the retina and to reach the diagnosis, but we have to plan the ideal use of these equipments for particular situations to get best use of these things. So direct ophthalmoscope, the advantage is the magnification here is 15x. It has got quite short learning curve. It is portable, can be taken to wards for bedside fundus examination. But the disadvantage is it has got only monocular view. We have to see the things with only one eye. So stereopsis is missing in this examination. But the diagnostic utilities of direct ophthalmoscope are a diabetic retinopathy, hypertensive retinopathy, and age-related macular degeneration, because these things are usually visible at the posterior pole of the retina. Then indirect ophthalmoscopy, the advantage is it has binocular view, so stereopsis is present, but the magnification is lower than direct ophthalmoscope, only 5x. It has got slightly long learning curve in comparison to direct ophthalmoscope, and it is not easily portable, because if it is to be attached with the electric connection, even if it is battery operated, even then also it is a big box, not easy to carry it to the wards. Diagnostic utilities are peripheral vasculitis, lattice, breaks, ROP, etc. And while examining retina with indirect ophthalmoscopy, you must know these coding colors for charting your findings. Then slit lamp biomicroscopy, it is a really good way of examination, but long learning curve, because first you have to learn the slit lamp examination, then use of 90D. So in this examination we can use either 90D or 78D. The advantage of 90D it has got wider view, but magnification is slightly lower. 78D has got narrow view but slightly more magnification. The big advantage of slit lamp biomicroscopy, it gives you binocular view, and magnification is adjustable magnification. You can see the things in magnified view also with the use of your slit lamp magnification. And stereopsis of course present in this equipment, and there but the learning curve is slightly long, as I told you, because first you have to learn the use of slit lamp, then 90D. And of course this is not portable. Patient has to come at the slit lamp. And diagnostic utilities are like CSME and CSR. In both of these, the disease is present at the posterior pole, and you need to have good binocular view to diagnose them. And particularly in clinically significant macular edema, this method of examination is required to label the things. Then B-scan is very important tool in retina examination, and the frequency used is 10 kilohertz, and in particular situations when the media is hazy because of cornea or because of cataract, then you have to use this equipment to diagnose the things behind. And sometimes you need to use it in uncooperative patient also, when patient is not able to tolerate the light and not able to cooperate your instructions. And sometimes you need to use it to confirm your ophthalmoscopic findings also, like in shallow retinal detachment or PVD, and also used to locate the intravitreal foreign body, and particularly posterior scleritis. This T sign is very important in B scan to confirm the posterior scleritis. And certain things like choroidal detachments are difficult to diagnose on fundus examination and need sometimes you need the help of B scan in such situations. FFA these days, this is going to slightly towards back seat because it's an invasive procedure, but still it's very important tool to detect and confirm the retinal neovascularization, to detect and or to rule out the macular ischemia, to detect or rule out the CNP areas in the periphery, to confirm leaky, whether the microaneurysm is leaky or non-leaky, so that you can plan your treatment accordingly, to detect and locate the leak point in CSR, so that you can plan for laser, and high diagnostic value in macular telangiectasia. So as you can see in this picture, you can easily see a neovascularization, capillary dropout areas, and laser spots also, plus microaneurysms. Very good tool to see all these things. Then wide field FFA camera, it has a range up to 200 degrees in comparison to conventional FA cameras who have range about 50 to 60 degrees. And this is very important to detect neovascularization at peripheral retina, to see severity of ischemia in retinal periphery, and very useful in Coats disease and ROP. OCT, this is getting popular these days because this is non-invasive procedure, and this is used particularly to examine the vitreoretinal interface, to quantify the macular edema in DME and RVO, to detect the and measure fluid in wet AMD, to monitor the progress of CSCR, to detect polyp in wet AMD. And you must know the normal OCT appearance, normal layers appearance, to make your diagnosis in OCT. And this is the learning curve is quite short in cases of OCT. So these are certain slides showing CSR, AMD, and diabetic retinopathy. Then OCTA, this is a very useful tool these days, particularly in some certain particular situations, and this is also non-invasive. It has a dual advantage of OCT and FFA. You can see the circulation without injecting the dye. It has got diagnostic value to detect CNVM at very early stage, to detect capillary dropouts at macula without injecting dye, and to detect RAP lesion, RAP lesion in wet AMD. And these are few pictures of OCTA. You can see very well the neovascularization in non-neovascular layers of the retina. ICG useful in a few peculiar situations, like to detect occult CNVM, to confirm polyp, and to demarcate tumors. But again, this is invasive procedure and not commonly available at many centers. Then this is non-invasive procedure, but this is of very useful value in certain conditions like retinal dystrophies and retinal degenerations, CSR, and choroiditis. And this instrument make use of your lipofuscin pigment, and can make out many useful diagnoses which cannot be diagnosed with other equipments. ERG not very commonly used, but very useful to detect the function of the retinal cells, and sometimes anatomy is normal but functions are deteriorated. You can use these equipments, and particularly this is useful in rod and cone dystrophies and retinitis pigmentosa. And as you can see in the picture, in abnormal cases and disease cases, the ERG is flat. Similarly, EOZ, this is very useful tool for photoreceptor disorders and breast vitelliform dystrophies, and changes you can detect easily in the reports. Amsel grid, this is used to monitor the disease, particularly CNVM, CSCR, and macular holes. And perimetry occasionally we do in retinal cases, particularly in BRAO and BRVO, not of very useful value. Thank you very much. So now I think we have come to conclusion of the session, and I once again thank Dr. Rishi for glaucoma talk, Dr. Saloni Gupta on cornea talk, Dr. Khalid Thakur for squint and oculoplasty, Dr. Nabil for very well cataract workup. Thank you.